So the topic was given was Hrt for all who saw. I just put a question mark there because by the end of this discussion, you should be able to make up your mind whether Hrt should be for everyone or not. You know this. When you start to have, when your estrogen level starts to decline, you will have some early symptoms. And then when the estrogen level is already low, you will have another round of symptoms or signs. And late into the menopausal age, if you are still alive by then you have a new set of problems altogether. So some of us in this room probably has hot flushes, being sweaty, insomniac, has menstrual irregularity with some psychological symptom. I was commenting that the hall is too cold, but some were saying, no, it's not. So probably you are at your early decline of estrogen. And as you progress or go on further, you will develop atrophy with some sexual concerns that Prof Nick is going to address later on, become atrophic, and it will not be so pleasant to have urge or stress incontinence. And towards the later on, you know this long-term condition like osteoporosis, atherosclerosis, coronary artery disease, and all. So why is this still a topic for discussion? Haven't we sorted out Hrt a long time ago? You remember Women Health Initiative that has been likened to an atomic bomb explosion? To who? To the company that produces the Hrt mostly. Because before that time, we were very confident that Hrt is the answer to all the problems. Your problem comes because you're estrogen deficient, you give them estrogen, problem's gone, right? But apparently the more senior people in the fraternity could tell us, I still remember when WHI trial was published. I was here and here and here at that time when the bomb exploded. That is the significance. So what, if you're younger, probably you're not very familiar with WHI. So basically, this is the conclusions from it. So we're looking at the hazards ratio, and you can see that it is after a mean of 5.2 years follow-up, and you can see that the range of age of the patient is between 50 and 79. So you will think that, is it fair to lump this together? The 50-year-old, which is very early in the menopausal stage, and the 79. And between 50 and 79, a lot of changes, natural changes would have happened. So if you're going to evaluate for the effect of hormone therapy, is that realistic to do that? But WHI, in a way, it does not draw a good conclusion because it lumps everything together, but this is what they found. But having said that, the data is actually very useful for us. So in coronary heart disease, the assumption before was that it solved all the problem, okay? But you can see coronary heart disease, the hazards ratio is 1.29, breast cancer 1 to 6, and the rest. So almost everything is increased, except colorectal cancer seems to have some reduction, endometrial cancer too, and hip fracture too. So all this went up, this actually went down. Death due to other causes, not significant. Total mortality, not significant. Okay. So there's some seemingly good thing with menopausal hormone therapy and some not so good thing. But what does it mean actually? The number seems huge, but if you were to look deeper into it, per 10,000 person years, you have 7 more coronary heart disease, 8 more strokes, 8 more pulmonary embolism, 8 more invasive breast cancers. And now the number doesn't seem so big anymore. Absolute risk reduction, it's not so fantastic either, but some reduction in colorectal cancers and hip fractures. So what does that tell you? You have to further analyze it and see who are the ones who get a reduction in risk, who are the ones who get an increase in risk. When they go through the data again, they found that, remember 50 to 79, for younger women, younger here refers to less than 60. In that sense, I'm very young. And also if you are within 10 years of menopause, not further than that. So they found that in younger women, your HRT use is associated with 40% reduction in coronary events and total mortality. Because they have an estrogen only arm, those without the uterus, and estrogen progestogen arm. So if you are on estrogen progestogen, hazard ratio of coronary heart disease is 0.89, the younger ones, compared to 1.7 if you are further on. So is it the HRT or is it the age? Okay. In those without the uterus, you are on estrogen alone. The younger one had a hazard ratio of 0.56, and the older women, it approaches 1. So this is a timing hypothesis. If you start it early enough in a young enough patient, menopausal patient, would you derive the benefit as compared to if you start it later in an older patient? So this is the stratification that has come about. Okay. So we can see the trend towards reduced mortality with HRT use if you are in the first 10 years of menopause. So that actually help us. If you look at your patient who say 65 and come to talk to you about hormone replacement therapy, you may not want to advise her that it's going to do her much benefit. What about stroke? Stroke is age dependent, as what we have discussed this morning. And this is another huge study, the Nurses Health study. Risk of stroke was increased, and you see with the higher dose, the risk increased further. Okay, estrogen plus progestin, not much different from the others. But if you look at the younger women or the women who are quite early into menopause, and if they take lower than traditional doses, this is traditional dose 0.625, they do not have elevation in stroke risk. And if you were to use a transdermal mode of delivery of the medication, the risk is not increased either. So again, younger woman, lower dose, and probably not oral. You can use the transdermal, and that does not increase the stroke risk, while the patient gets benefit from all other benefits of hormone therapy. Cancers are most worrying in a lot of people, and as I said, we are not winning the battle. So do you want to add on to the risk? The finding was that current E plus P has an increased risk of breast cancer, 1.75, but not if you use estrogen alone. And the risk is increased within the first 2-3 years of therapy, and after you have stopped it, the risk will come down. Okay? That's about breast cancer. So that's a real concern. If you talk about ovarian cancers, if you compare those who took hormone therapy and the one who did not take hormone therapy, there seems to be an increased relative risk. All ovarian cancers and epithelial ovarian cancer. And the risk decline after you stop therapy. The same findings or the same concern has been shown for lung cancer also. Okay, and you know, breast, lung, ovarian are still the top cancers that Malaysian women suffers from. Okay, but the number is actually quite small, and you may not deny a patient who needs hormone therapy just because of the concern about ovarian cancer risk. That's what we're seeing. This is a later study. Remember, WHI is in 2002. This is from an American study. So what it does was, it looked at low dose oral. Remember our traditional of 0.625. This used 0.45, or use transdermal with cyclical monthly progesterone, and this is a younger women. So they found that many favorable effects of hormone therapy. Okay, And they conclude that estrogen progesterone treatment started soon after menopause, in a younger woman of course, relieves menopausal symptoms, improves mood, bone density, and cardiovascular risk markers. The key point is again younger women. Okay? Which means despite all the scares, you should not deny them if they need the hormone therapy to treat especially vasomotor symptoms. This is another one who studied the timing theory. If you intervene early compared to when you intervene late. So the two groups were those who are within 6 years of menopause and another were more than 10 years of menopause. So they look at the progression of atherosclerosis and measure the carotid intermediate thickness. And they found that there is a positive effect of a slower progression to atherosclerosis if you take HRT, if you are younger. Okay. In this case, the older people might feel discriminated because their results are all not favorable. Okay. Right. So, if a patient comes to you asking to or be counseled or discuss about menopausal hormone replacement, you will use some guideline in which there's no standard regimen because there's no standard woman. So it depends on age. The benefit is bigger to the women during menopause transition, meaning the younger one, than the older one. If you're younger than 60 years, you shouldn't be unduly concerned about the safety profile. Okay, but you don't give it to everyone. Like you give vaccines to everyone, right? But you don't treat menopause or hormone replacement therapy the same way. You have to have an indication. Okay, and commonest indications are vasomotor symptoms or urogenital symptoms. Okay, to start after they're already 10 years from their last menstrual period are not considered not appropriate. And you do not use it solely for disease prevention like cardiovascular disease and the other chronic diseases. And use the lowest dose possible because we have shown the higher dose has higher side effects or risk. Okay, so far? Right. How long to give? Okay. There was some guidelines some years ago that says only give for 2 years and revise. So lowest dose, shortest duration possible. Let me reassure you that's not quite true anymore. The lowest dose possible is still holds, but not the duration. Okay? So basically, if they derive symptomatic benefit, you use it, but you have to re-stratify and you have to have follow-up and monitoring. Should you discontinue after you're 60 or 65? It depends on the situation. A patient of mine is already 60 years of age and has been taking this for about 10 years plus, and she's asking, do you think I can stop the hormone therapy? So, are you having any problem with it? So, none whatsoever. And she comes for follow-up and all her parameters are good. And I said, you may want to give it a try, stop it, and see whether you're happy with it. So she stopped. So again, 6 months later, he said, not happy with it because the symptom came back, although she's already 60. So she continued for a bit more. Okay. If you have premature ovarian insufficiency, Dr. Muri will talk about that a little bit later. You can continue until at least the average age of natural menopause, and subsequently if she still needs it. Right. So this is what I've mentioned to you about the patient just now. Did the mic just go off? You trying to tell me something? Okay. It's not consistent. But anyway, doesn't matter. So to the question of HR, is it for everyone? You know the answer already, right? There's nothing that is all or none in this life except you have been born and you will die at the end of it. Other than that, everything is individualized. So my take-home messages, I have 4 messages for you to take home. This should be better.
Yeah.
Alright, they promise this is a better mind. As with anything and everything, you individualize it. So the option is in an individual decision in terms of quality of life and health priorities, as well as personal risk factors such as your age, your time since menopause, and risk of thromboembolism, stroke, coronary artery disease, breast cancer. The same way, dose and duration, the smallest dose possible, and the duration is for as long as the patient needs it, and the benefit derived is bigger than the risk. If you are younger, then it's better in terms of menopausal hormone therapy, because we have shown reduction in coronary artery disease and all-cause mortality, effective vasomotor symptom, and to some extent prevention of osteoporosis, because it delays the osteoporosis progression. In regards to breast cancer, estrogen plus progesterone has higher risk compared to estrogen alone. Okay. And finally, if you are young and you start HRT early, it will delay the progression to osteoporosis and to some extent will prevent it. Okay, so I promise you 4 take-home messages, and that's all. Thank you very much. And this is the rose garden.